Bismillahirrahmanirrahim. Rabbi zidni ilma. Quote of the day. These pains you feel are messengers. Listen to them. Assalamu alaikum everyone. My name is Dr. Sadia Rafi and under the supervision of Professor Dr. Sara Afzal, today my topic of presentation is screening of disease. Learning outlines include the introduction of screening, types of screening, criteria for screening, sensitivity, specificity, negative predictive value, positive predictive value, reliability, recent advances, and multiple choice questions. At the end of this presentation, participants would be able to describe the screening, types of screening, sensitivity, specificity, negative predictive value, positive predictive value, and reliability. Introduction. The biggest challenge in preventive medicine is to distinguish between people who have the disease and those who don't. If we see the iceberg phenomena, this gives an idea of progress of a disease from its subclinical stages to overt disease. Hidden are subclinical cases, carriers, and undiagnosed cases. The search for unrecognized diseases or defects by means of rapidly applied tests, examinations, or other procedures in apparently healthy individuals. Earlier, it was so conserved physicians' time for diagnosis, administer inexpensive lab tests, etc. But today, screening is considered a form of secondary prevention. It detects diseases in its early asymptomatic phase, whereby early treatment can be given and disease can be cured, or its progression can be delayed. So if we see the prevention natural history of this disease, you can see biological onset of the disease starts from here to the outcome. And this is the promoting health and primary prevention area. This is the tertiary prevention, which is rehabilitation support. In this preclinical phase and clinical phase, this is the point which includes a secondary prevention, which includes a screening and early detection, where the symptoms appear and treatment after that. So it is a potential improvement by screening can be done. Talking about the lead time, the advantage gained by screening, it is the period between diagnosis by early detection and diagnosis by other means. So biological onset of the disease and it is the outcome. And it is the lead time where the symptom and diagnosis, detection by screening. So screening programs work better when the time lag between the disease onset and its final critical point are sufficiently long. Talking about the differences between screening and diagnostic tests. Screening tests done on apparently healthy individual, whereas diagnostic tests are done on sick or ill individuals. It is applied to groups. It is applied on single patient. Results are arbitrary and final. Diagnosis is not final. In this case, based on one criteria and cutoff. Whereas the diagnostic test is based on evaluation of a number of signs and symptoms of lab findings. It is less accurate, it's more accurate. It is less expensive, it's more expensive. It's not a basis for treatment, but diagnostic tests are used as a basis for treatment. Initial come from the investigators, where the initiative comes from the patient in diagnostic test. Uses of screening. First of all, case detection. In this, there is a prescriptive screening. It is defined as the presumptive identification of unrecognized disease, which does not arise from a patient's request. Like neonatal screening, the people are screened primarily for their own benefit. So you can see here is the heel prick blood sample. Second is the control of disease, which is prospective screening. People are examined for the benefits of others. Screening of immigrants from infectious disease like Ebola, TB, and syphilis to protect the home population. Screening for HIVs, STDs, etc. Screening program may, by leading to early diagnosis, permit more effective treatment and reduce the spread of infectious disease and mortality. Third is research purpose, to know the history of many chronic diseases like cancer and hypertension. Screening may aid in obtaining more basic knowledge about the natural history of such diseases. Initial screenings provide a prevalence estimate and subsequent screening provides an incidence figure. Fourth is educational opportunities. Screening programs help in acquisition of information of public health relevance, providing opportunities for creating public awareness and for educating health professionals. Moving towards the type of screenings. First is mass screening, application of screening test to large unselected population. Everyone in the group is screened regardless of the probability of having the disease or condition. Visual defects in all school children, like mammography in women and colonoscopy for occult blood. Second is the high risk or selective or targeted screening, the screening of a selected high risk group in the population, like screening fetus for Down syndrome in a mother who already has a baby with Down syndrome, or screening for familial cancer like hypertension and diabetes, screening for CS cervix in low socioeconomic status women, or screening for HIV in high risk groups. Then comes a multi-purpose screening, the screening of a population by more than one test done simultaneously to detect more than one disease. For example, screening of a pregnant woman for venereal diseases, HIV or hepatitis B by serological tests. 4 is multiphasic screening, the screening in which various diagnostic procedures are employed during the same screening program. For like in case of diabetes mellitus, fasting blood glucose level and glucose tolerance test is done. In case of sickle cell anemia, CBC and hemoglobin electrophoresis. Criteria for screening. Before initiating a screening program, a decision must be made whether it abides to all the ethical, scientific, and financial justification. The principles that should govern the introduction of screening programs were first enunciated by Wilson and Younger in 1968. The criteria for screening is based on two considerations. First is disease and second is screening test. Disease. The disease should be important health problem. It should have high prevalence like TB. Disease should have long and detectable preclinical stage. The natural history of disease should be adequately understood. Appropriate tests must be available for early detection of disease before signs and symptoms appear. Facilities must be available for diagnosis of disease, like information good standard tests. Then the early detection of disease and treatment should be able to reduce mortality and morbidity. The disease should be treatable and there should be a recognized treatment for lesions identified before following screening. Expected benefits must exceed risk and costs. A policy should be agreed on concerning whom to treat as patients. Talking about the screening test, they should be inexpensive and easy to apply. Simplicity should be there. Acceptable, valid, reliable, and yielding. Simplicity. The test should be simple to perform, easy to interpret, and where possible, capable of use by paramedics and other personals. For example, blood and urine test and ECG for early detection of hypertension. Then comes acceptability. Since participation in screening is voluntary, the test must be acceptable to those undergoing it. In general tests, they are painful, discomforting, or embarrassing are not likely to be acceptable. For example, screening for prostate cancer might not be acceptable to a large population of the community. Now comes the what is valid and what is reliable. Validity is the accuracy of the test, whereas the reliability is the precision of the test. So if we see the accuracy is how close is the result of the test to its true value. And in precision, how close are the results of a test on repetition. So if we see here in this, there's low accuracy and low precision. Here low accuracy but high precision. High accuracy but low precision, and it's high accuracy and high precision. Validity. Validity determines the accuracy of the test. It expresses the ability of a test to separate those who have the disease from those who do not. A test with little systematic error is a valid test. The components of validity are sensitivity, specificity, and predictive accuracy. Sensitivity, the ability of a test to correctly identify who have the disease. Those are called true positives. Proportion of truly ill population, and if you see in the 2x2 table, it's a gold standard test, disease present, absence, test positive, negative. This column shows the sensitivity. Expresses percentage true positive divided by true positive plus false negatives. If you see the picture, so sensitivity is true positive over true positive and false negatives. Be sensitive to those who have disease. So sensitivity screening. Specificity, the ability of a test to correctly identify those who do not have the disease. Those are true negatives. So the proportion of truly healthy population. So in this column is for specificity, including false positive and group of true negative. And you can see here, so specificity is true negative divided by true negative plus false positive. So negative people get specific. So the specificity is equal to confirmation. So in this test, the two characteristics in population disease or no disease in this 2x2 table, if we want to calculate the sensitivity, so I have told you it is by true positive divided by total. So 80 by 100 would be 80%. And in this case, which is specificity, true negative divided by total. So it is like this and it is 89%. An ideal screening test should have 100% sensitivity and 100% specificity, but not practically possible. False negative, if a person with disease is labeled negative. So, false reassurance ignores any disease sign and symptoms, postponement of treatment, and detrimental to overall health. It would have low sensitivity and high specificity. False positive, a person without disease is labeled positive. So what would be the result? The further testing with long, expensive tests, discomfort, inconvenience, and anxiety, burden on health facilities, emotional trauma, and difficulty in delabeling. So high sensitivity and there should be low specificity. If we see the bimodal distribution, the true positives would be like this and negative would be like this, but in unimodal distribution, all results will come like this. Concept of cutoff point. Unlike in bimodal distribution, which is dichotomous, some diseases comes in continuous variables like diabetes and hypertension. In these cases, it is difficult to calculate sensitivity and specificity. So a cutoff point must be set to distinguish between positive and negative result. So if we see these are diabetics, these are non-diabetics, this is high blood sugar levels and this is low blood sugar levels. So we consider 20 diabetics and 20 non-diabetics screened using a blood sugar test, vertical axis from low to high. Now, if the low cutoff value, so what these are the results with the low cutoff value. In this, you can see the sensitivity is 80%, 85%, specificity 20%. So what it means, false positive originate. More non-diabetics are diagnosed positively because our cutoff value is quite low. But in this case, if we have high cutoff value, you see like this. So now the result is this, sensitivity is 25% and the specificity is 90%. So false negative originate. More diabetics are not diagnosed positive. So different cutoff points yield different sensitivities and specificities. The cutoff point that identifies more true negative will also identify more false negatives. The cutoff point that identifies more true positive will also identify more false positive. The choice of a high or low cutoff levels for screening, therefore, depends upon the importance we attach to false positives or false negatives. In case of lethal disease where early detection invention possible, cutoff point must be set at low level as greater sensitivity is required. False positive can be tolerated. Multiple tests. Sequential testing, two-stage. At the first screen test is conducted, those who tested positive are brought back for the second test to further reduce false positives. Consequently, the overall process will increase specificity with reduced sensitivity. Net sensitivity and net specificity can be calculated by both the tests in sequence. Net sensitivity falls, but net specificity will be gained. Simultaneously testing. Two or more tests are conducted in parallel. The goal is to maximize the probability that subject with the disease, which are true positives, are identified. It means there is high sensitivity. Consequently, more false positives are also identified, shows specificity low. Net sensitivity gained, but net specificity will be lost when compared to either of the tests. Predictive accuracy. Positive predictive value, the proportion of the people who is screened positive that actually have the disease are the people with disease correctly identified. Negative predictive value, the proportion of the people who screen negative that are actually free of disease are the people without disease correctly identified. These values are not fixated for a particular test. You can see in this 2 by 2 table, the positive predictive value goes like this side, 80 true positive divided by total, and in case of negative predictive value, which shows a true negative divided by total. So positive predictive value 80 by 844%, and true negative value, if we divide 80 by 820, is 98%. Positive predictive value direction goes like this and negative comes like this. Predictive value depends upon the prevalence of the disease and specificity of the test. More prevalent disease, high positive predictive value. That's why screening is more efficient and productive if done in high-risk population. Increasing in sensitivity causes a modest increase in positive predictive value, but increase in specificity raises positive predictive value markedly. Reliability. Reliability determines the precision of the test. It means repeatability. It means that all the results of the test should be similar, clustered at one place when conducted each and every time. This is not possible because of the variation that cause the test to not yield same results every time, like lab equipment failure. So there are three types of variation: intra-subject variation, intra-observer variation, and inter-observer variation. Intra-subject variation. This is the variation is the result of the test conducted over time for the short period the same individual. The difference is due to the changes that occur to the individuals over that time period. So if we see the blood pressure levels in females, 27 years, 62 and 33 years old male, you can see the variation. The basal would be 110 by 70, lowest 86/47, highest this and this. So variation BP during a 24 hours period, it is the normal for everyone. So it is intra-subject variation. Talking about an intra-observer variation. This is the variation in the result of the test due to the same observer examine the result at different times. So the person is one. For example, 2 readings of blood pressure by the same observer. Next comes the inter-observer variation. This is the variation, the result of the test due to multiple observer examining the result. So multiple observers, more than 2 or 3 observers are examining the result. For example, the chest X-ray read by 2 different radiologists. So the test result obtained are shown by the curve. The curve is broad and narrow. In this case, the test result is valid but not reliable. Test result valid and reliable. And tests are reliable but not valid. Yield is the amount of previously unrecognized disease that is detected and brought to treatment as a result of screening, and it includes true positive, false positive, including all others. It depends on prevalence of the disease and sensitivity on the screening test participation in the program. Yield of the screening test is high in high-risk screening. Evaluation of screening programs, experimental. Conduct an RCT of the screening test to compare the disease-specific cumulative mortality rate between the intervention and control group. Problems include long follow-up, cost and record keeping, a loss study of distribution of lead time, effect of early treatment, and identification of prognostic factors. And in non-experimental cohort study, comparison of advanced disease or death of rates in those who choose to screen and those who do not. Case control, comparison of screening history in those who have advanced disease and those who are healthy. And ecological study, correlation of screening pattern and disease experiment of several populations. So popular screen tests, you can say like mammography, different pap tests. In mammography, the sensitivity is 75 to 95% and specificity is 83 to 98%. Conclusion: screening, despite its flaws, a major public health determinant and measured by its effects on mortality, morbidity, and disability. Establishing appropriate criteria requires considerable knowledge of the natural history of disease, adequate facilities for follow-up and treatment. It is necessary to ensure that the program is continuously monitored to confirm the effectiveness is maintained, like benefits are more than cost. Newer suites such as genetic screenings, orange rice switches would help the cause. Moving towards the recent advances. So the role of imaging in screening special feature, Coventry screening and surveillance principle and practices. In this, health screenings can only be applied to the population, not individual. Fit to be effective, the initial screening test must be acceptable and reasonable and accurate. The disease must be treatable with better outcome when treated early, and the harm and the cost associated with screening must not overweight its benefit. Next come one of the article assessing the value of screening tools, reviewing the challenges and opportunities of cost-effective analysis. In this, the screening is as important part of preventive medicine, and screening tools identify patients early enough to provide treatment and avoid or reduce symptoms or other consequences and improving health outcomes. So again, it is shown that all the patients with difficult identifying data sources, the screening should be done and it is important part of the preventive medicine. One of the article approaches to nutrition screening in patients with coronavirus disease 2019. In this, the malnutrition is common amongst male patients with coronavirus, and it views the available literature. Nutritional screening approaches implemented among COVID-19 patients with special focus, and it shows that a simple measure based on routine conduct laboratory investigations, and this assessment helps to detect residual malnutrition, high malnutrition risk in remitting patients. And one of the over-testing of SARS-CoV-2 with virus that causes corona screening tests provide important information to limit transmission and outbreaks in high-risk congregate settings. So genetic health screening is new thing taking healthcare to new level. Genetic cancer screening, cardiovascular, brain infection, genetic disease screening, and drug and medicine genetic screening. So screening tests to detect a developing disease in future indicate all these that the analysis of gene can help identify risk factor for a variety of diseases that would allow doctor to use the data as an appropriate guidelines for personalized healthcare advice for each patient, which will help them in taking good prevention and implement precise treatment. In addition to that, the genetic screenings can reduce the cost of treatments as well. Now moving towards the multiple choice questions. First is screening patients for preclinical disease is an established part of routine medical practice. Screening test specificity is the ability of a test to correctly identify false positive, true negative, and false negatives.
C.
Yes,
C.
true. Yes, that's the correct answer. Results of the screening test for diabetes compared to confirmatory tests, oral glucose tolerance, and the specificity of the test is. How we calculate the specificity? I show you the solution. The specificity is like true negative divided by total. So it would be 500 divided by 520. And the answer would be 96.1. Got it?
Got it.
Yes, yes.
Yes.
Thank you. The next MCQ is a comparison of clinically diagnosed versus autopsy-confirmed gastric and peptic ulcer were performed on 750 consecutive disease patients in several large hospitals as shown in following table. From these data, the sensitivity of the clinical diagnosis is, what would be the combination?
D. C.
D, exactly. So the sensitivity is the true positive divided by total. So D is the correct answer, 100 over 250. Sensitivity is the first column. Which of the following characteristics is not of much importance in the screening test? Low cost, high safety margin, high sensitivity, high specificity.
A.
D. No, the correct answer is D. Screening test should be low cost, it should have high safety margin, high sensitivity, but the last one, high specificity, is not of much importance. So D is the correct answer. Results of screening test for hypertension in ABC community. The sensitivity of the test is, what would be the answer? Any guesses?
B.
Absolutely right. B. This is the 100 over 300. True positive and total. Next question. 50 lateral radiograph of patient with a single level cervical degenerative disc was selected and measured on two different separate occasions by 3 spine surgeons using 3 different measurement techniques. Cervical sagittal rotation was measured using 3 different techniques which showed different results from 3 surgeons. The type of variation in this scenario is intra-subject variation, inter-subject, intra-observer, inter-observer.
C.
Anyone? No.
A.
The answer is D, inter-observer. I have told you there are 3 surgeons. So inter-observer, number of surgeons is increased. So D is the correct answer. Results of screening test for prostate cancer in XYZ community. The positive predictive value of test is, what it could be? Positive predictive value. So I have told you it
D.
350 over 600 it would be. So the correct option is, seventh is A.
A.
Yes. Mr. Larry received 10 chest photographs of the COVID-19 patients on 2 separate occasions. On the first occasion, he documented no finding in the chest X-ray. The next day, he found pulmonary opacities in 6 by 10 chest photographs of COVID-19 patient. The type of variation in this scenario is intra-subject variation, inter-subject variation, intra-observer variation, or inter-observer variation.
Alpha. A.
C. The surgeon is
C.
saying, and on different timings, he has this observation. So C is the correct answer. Results of screening test for breast cancer in ABC community. The negative predictive value of test is what it could be. Negative predictive value.
C.
Yes, the C is, because positive predictive value goes like this and negative like this. So 200 divided by 350 by 57%. Hypertension is rising in the XYZ community. The health department started a screening program for hypertension. Hypertension screening is more productive and efficient when performed on high-risk population because of more prevalent disease has. A, high positive predictive value, low PPV, high negative predictive value, low NPV, or low sensitivity.
Alpha.
E. Yes, alpha is the correct answer. It should be high positive predictive value. This is my key. This is our YouTube link. And this is the reference, and thank you so much.
Thank you very much, Dr. Sadia. Wonderful presentation. A lot of hard work has been put in, and a very important topic as far as sensitivity, specificity, positive predictive value, negative predictive value is concerned. We also know that we also calculate the diagnostic accuracy and yield by these parameters. So these are very important for the further elaboration of analysis and knowing the importance. I just want to add one thing, that there is another very important thing that is also used for the sample size calculation. When we have the sensitivity and specificity studies, we always calculate the sample size on the basis of sensitivity and specificity. So we have two important things to consider. One, we can use a formula for sensitivity and specificity, and we can put the values to calculate the sample size. The second thing is we